What am I going to do? I've been commissioned to speak to you today, and so what I'm going to do is ignore the commission and tell you what I think might be something interesting and slightly different than you might otherwise have heard. And I'm saying that because, in my view, commissioning has been the curse of social care. I've been reflecting on this. I'm doing a piece of work on commissioning, and I've been reflecting on what's changed. 25 years of commissioning. What's changed in our social care system? Very, very little. What I was involved in running, from a council's point of view, domiciliary care 40-something years ago. What's changed in the way we run domiciliary care over the last 50 years? Very, very little. There are some small, interesting examples, but we pretty well keep doing the same old thing, and in my view, we keep making the same mistakes. It's probably slightly easier for you to hear that message because you do what you're commissioned to do. In fact, I don't think anybody actually anymore commissions domiciliary care. They procure it. They procure it as cheaply as they possibly can and don't give any real thought to actually what we're trying to achieve. So that's going to be the theme of what I'm going to talk about. I'm going to look at 4 different aspects of domiciliary care. I'm going to touch on the fact that I know you, Age UK and everybody else, produces loads of evidence about how people need more domiciliary care. My evidence includes that actually there's a cohort of people who are overprescribed domiciliary care. And that's a group that interests me. My second contention is, for goodness sake, why is domiciliary care seen as a single service? It is not. It is a range of services meeting different kinds of needs of different people in different ways. Let's explore that. And then I suppose this whole question about, well, if we insist that domiciliary care is a commissioned service, what are we commissioning? Are we commissioning for time and task? That's what I'm on this morning. Keep an eye on the clock. Or actually, should we really be moving towards commissioning for the outcomes, that the help we give people and the difference it makes to their lives? That should be what we commission for. And then finally, mainly because Colin and I are going to do some work in Wales, we think, fairly soon together on the cost of care, following up some work I'm just completing on the cost of care, residential care in Wales. Let's just have a little think about, within all of this, the costs of care. So let's start with we'll start with probably the most contentious area that some people here may find difficult. Big study completed about 18 months ago, commissioned by the Local Government Association, undertaken by consultants at a company called Newton Europe, tracked 2,000 patients in 5 different parts of the United Kingdom and followed them through hospital. Followed what happened to them prior to admission, what happened to them on admission, what happened to them in hospital, and what happened to them on discharge. Loads of wealth of kind of evidence and information there. Very interestingly, just to kind of like a very small aside, not what I'm going to particularly focus on, very little evidence from that study that what social care does can make a big impact on admissions to hospital. People's admissions to hospital were much more related to failures in the health service than any identified failures in the social care system. There were some examples of poor services, poor residential care, poor domiciliary care, contributing to a hospital admission, but actually not getting domiciliary care, not being in residential care, didn't particularly feature. It's a very small part of that sample. But what it did show was at the point of discharge, this big thing that everybody talks about every day and everybody worries about, 1 in 5 people are overprescribed the level of care they need. Now, I reckon if I actually sit down with some of you and your staff, you'd recognise that. You'd recognise the people who are rushed out of hospital, told you that you need some care, and when you get to visit them, you're a bit kind of concerned about, well, what is it actually they really need? And was it just the anxiety of the staff? That isn't just about domiciliary care. That also includes double-handed, the overuse of reablement inappropriately, and use of some residential beds inappropriately. But that's a massive figure if you think of all the patients who are discharged. In fact, I sometimes say, if we could solve that problem, we might solve quite a lot of the rest on its own, because that's about, it's about 60% of demand on the social care sector for older people comes from the acute hospital. Very interestingly, that figure varies enormously from one place to the next, so don't quote it as being your area, you need to know what your area is. Very different figures. I'll say a bit about that in a minute. People need to understand this. Where you live in the United Kingdom, and I work across the United Kingdom, there is a massive difference as to what happens to you, depending on what service you get, what your social care system's like. One of the biggest challenges in social care is, despite 15 years of quite good research, we still haven't really grasped and understood that the ability that in old age for people to recover from quite serious conditions and the levels of recovery which people can make. Rather foolishly, I say, local authorities have tended to keep a service they call reablement to themselves. They sometimes call it their service of last resort. Yeah, quite. The evidence of what is reabled in that service varies enormously from some really very interesting, very well-developed service, a minority, to some services that do no more than prop people up with a care package until they can pass over to yourselves. There's a real lack of understanding in the health and care system on recovery. In fact, if you go back to this argument about commissioning, it is really rare, given all the debate, to find that local authorities and NHS, collectively, separately, are together commissioning an out-of-hospital care system. Just doesn't, just very rarely happens. Do find it, and of course, in my work, I really encourage people to do that, to design a system and to be clear what the outcomes you want from that system, to bring providers together and to be clear with those providers what those outcomes might look like. So there's a real confusion about where recovery fits in, where it fits into the role of domiciliary care, not thought through. Less so these days, but in the early days of domiciliary care, of course, there was a lot of use of domiciliary care for tackling social isolation. Lots and lots of research evidence, not just from the United Kingdom, and some colleagues from Australia. There's some very good Australian research. One of the interesting things about Australian research is they tend to do it longitudinal, over a longer period than we mostly do in the UK, as they do also in the States. So you get better evidence, because you can see over the longer term what happens. England, in the United Kingdom, we look for kind of 3 years, and that's kind of like, that's our finding. There's a couple of 10-year studies of old age, for example, in Australia. All the evidence about tackling social isolation, none of it suggests that domiciliary care is part of the solution. Again, I'm not blaming yourselves for this. This is what social workers do when they kind of do their assessments. There's a kind of view that we might use domiciliary care just to keep an eye on someone. Again, is that the best use of what is and I'll come on to why I think it's a really important resource. Probably not, particularly with all the assistive technology that's now available that can support that. And then probably one of my most controversial statements, which again comes from studies in Australia and studies in Canada, but absolutely is borne out by what I've observed in my working life, is once somebody enters the formal care system, they are likely to deteriorate. And it's not a necessity of life that that person will deteriorate. It's what we do when people start to give up, when people start to receive care. And I think we tread a really careful line in the care business between rightly caring for people who need care, but not doing it in such a way that actually disables and limits people's long-term prospects. The Canadian study, for example, indicated once you enter the formal care system, domiciliary care in particular, your risk of needing more care increases by 120% in the first year. So, a kind of real challenge. A lot of these challenges actually are for assessors, are for social workers, for people who are assessing people. You'll see at the very end, I even wonder whether we should actually relook at that. Because in my old days, as you can see, I'm an old man, in a local authority, the domiciliary care staff assessed people for domiciliary care and arranged that service. I don't think there was any research which suggested that was a bad way of doing things. I'm just going to use one bit of evidence. There's loads of stuff. If people are interested, I've put some references on the back slide. I mean, I've written loads about all of this stuff. I'm just using one bit of current thinking that's going on in the UK. So we've used, though actually, again, the Australians will be getting a good mention today. A lot of their research is based on that 10-year study from Australia. Newcastle Institute of Ageing, a company called ADL Smart Care, you may have come across, who are promoting a model which actually really shows the massive difference you can make in the life expectancy and in the quality of life of older people, depending on the way in which you help them. And in very rough terms, on the bottom left, you can see the rapid decline straight into kind of thinking I think we have to get into all care services, but mostly, particularly into the future of domiciliary care. So I won't dwell on this slide, just there are massive variations. Some of you may have come across the work I did at the Department of Health. I know Bridget and Colin were involved at the time, which showed that where you live in the United Kingdom, what will happen to you in old age will vary massively. Something like a 6-fold variation as to whether or not you're likely to end up in residential care, depending on where you live. Nothing else, not to do with demography or poverty or other features, just on where you live. And some of that's to do with assessments, some of that's to do with the way services are delivered, some of it is to do with the menu of services, the range of services on offer and what is on offer in a particular area, and some of it, in my view, is to do with what we think is called, what we call success. I'll come back to that. So, I heard a few murmurs and nods when I suggested we really have got to get away from the idea that domiciliary care is a single service. Sorry, I know I'm preaching probably to the converted. This is a message for commissioners, not for yourselves, but at least I might give you some ammunition for the next time you're facing some commissioners who are yet again going to procure by cutting and pasting last year's or the 3 years ago procurement process and try and wallop down price on care. There are a range of different kinds of services requiring different skills from staff, requiring different kind of assessments, requiring different interventions in different ways for different people. In fact, I think I'd argue that is what personalisation is. It's recognising the right kind of help for the right person in the right way. I've only made a kind of headline list here. I'm sure all of you could add and we would have subsets of the list. Short-term recovery, longer-term recovery. People, for example, we might say recovering from a stroke. The key issue for most people receiving domiciliary care is how do they live with their long-term condition or long-term conditions? How are we helping them manage, whether it's through their diet, through exercise, through medication, a whole set of things we need to be absolutely clear on, that with this set of conditions, in your circumstances, these are the best ways of helping you. And it ain't kind of like 15 minutes in and out, I'll tell you that for free. Even more insignificantly, within a subset of long-term conditions, of course, are the challenges of dementia. And again, it's a bit like delayed discharges. Everybody talks about it. Everybody kind of pontificates. The solutions that have been put forward have been the same for 10 years, and we're still in a crisis. Everybody talks about dementia and its problems of the future. There's loads of evidence. I don't know if there's anybody here from Alzheimer's Society. I mean, Alzheimer's Society websites across the UK are full of really good information about how best to help people live with dementias. The kinds of things that best help people relax, reduce the stresses and the anger and the frustrations that some people with dementias explore and hit out at. Now, I do know that Jane, a friend of mine from Somerset Care, Jane and I have talked a lot about in Twitter and in meetings about the importance of actually creating a specialist domiciliary care service for people with dementia. In fact, I came across Jane and that service when I was doing a review of the model of domiciliary care in Wiltshire 5-6 years ago. Fantastic service. Was it Silver? Petals, just a brilliant service. And actually, if you're looking for an outcome from that service, really impressive service, really impressive staff who were supported, trained, paid a little bit more to deliver that service. Oh, I have to hasten to add, I hope Jane doesn't mind me saying this, she wasn't commissioned to run that service. No one actually said to her, develop a dementia care service. She's a businesswoman, understood social care, knew that that was actually what she needed to do to meet the needs of that sub-cohort of her wide group of patients, clients, people, older people she was helping. And I think I'm right, Jane, but I'm sure you'll correct me later if I have got this wrong. At the time we were last having conversations about this, for a 2-year period, that domiciliary care service had sustained a set of older people with dementia in their own homes without a single admission to residential care. Wow, I'd pay for that. Wow, that's an outcome I'd want both for my mother and for the social care system. But do councils commission for dementia care? Very, very rare. So a real challenge to kind of recognise these different services. A totally different model of care is required when we get to end-of-life care. It's a different kind of service, different kind of involvement, quite tough on the staff, different kind of support mechanisms required for them, different ways in which they would work, for example, with and alongside nursing services. So, major contention. The future of domiciliary care cannot continue in the way it has for the last 50 years. It just won't deliver what's required. And I plead to you to start that conversation with your commissioners, because unfortunately I don't see them yet leading that debate, because they're still hiding behind some kind of austerity procurement model. Actually, if we got this right, we would reduce the costs on older people in the care system. This would actually save us money, and I can demonstrate that from places who've done parts or variations on this. Oh yes, this is just to recognise that, of course, whatever happens in domiciliary care, it has to end up being a part of a whole set of other community interventions. And we can't continue for it to work in isolation. It has to be seen as part of community services and not a kind of a standalone service. So then, very briefly, I've written a lot about this. You can read papers on the Institute of Public Care website on this. It is my contention, given what I've been saying, that actually we can make a big difference to people's lives by the way in which we care for them, by what we kind of do when we receive people who may be in a really difficult circumstance, may be very frail, but we can, for some people, not for everybody, it doesn't work for everybody, but for a significant proportion, we can change their lives, we can help them recover and rehabilitate, we can help people better manage their long-term conditions. I would certainly suggest if we were doing that well, we would see less episodic episodes of people going into hospital. We can work alongside carers, supporting them, and we can help more people remain in their own home and inadvertently continue to reduce admissions to residential care. My contention for social workers is they should be writing care plans that actually focus on the outcomes that they want to see care workers and others in partnership deliver. And that needs to be the future of social care. There is a big mistake in the Care Act because they focus still on an old-fashioned term called assessment, whereas actually what matters is not the assessment, because assessments change over time. What matters is the intervention and the way people get their help. And again, the few places, and I've been to visit places that have moved, I have to say this carefully, because a council will claim it's moved to outcome-based commissioning, and when I go and visit, it's no more outcome than anything I've ever seen before. But the staff actually are quite encouraged by the language of outcomes. It gives them a kind of greater sense of purpose. And that couple of months I spent in Wiltshire, I was very struck by how the staff bought into what actually was required for them. So I do think it's one of the kind of possible levers for giving people the job satisfaction that the current model fails at times to give. On the outcomes models, there's lots of outcomes models. You can do it by payment by results, which is the model that Wiltshire started. Incredibly cumbersome, incredibly bureaucratic, and quite expensive to run. It was a good idea, but I'm not sure whether that actually is sustainable as a long-term way of doing it. What we've begun to do with a handful of places across the UK, so this is Wales and Scotland as well as England, is start trying to find the performance indicators that you'd look for from the service as a whole. And we're beginning to identify, and I've written a whole paper on this, what might be the things, so responding quickly, that's quite an important indicator, I think we might go for that. Reducing demand for domiciliary care over time, for a proportion of people. And most of all, the actual impact that domiciliary care can have when delivered properly and well on reducing admissions to residential care. And I think we could move without a massive bureaucratic change, just with a kind of cultural change to an outcome set of focuses that are as simple as those objectives. And those objectives were in the 1990s white papers for social care. They ain't anything new or radical or very different. They just got lost in every other white paper, green paper, black paper since then. So, just to conclude, I think I'm just about gone on time. I've got to go on to the next job. No, I haven't. I'm staying. Cost of care. Just recognising there's a set of variables for the cost of care. People haven't got a clue what the cost of care is. I'm sure Colin will bear this out later. They don't even understand what the things that actually are making up the cost of care. And so when councils are kind of procuring something, they haven't really thought through what those issues are. They tend to look at history and what did they get away with last time and can they get 10% less. I highlight training. Obviously, in the model that I'm describing, you do need a better trained workforce in order to deliver it. I understand that. In the residential care debate, one of the debates we've got into is what is a reasonable return of profit for a company that's delivering a care service primarily when it's supporting the public sector. And actually, we're going to take a view on that. We're going to take a view on this is a reasonable return. It's not as high as Mr. Lang and Buisson's excellent work on this, but it's not much below. Watch this space. And I suppose the last challenge, which kind of like interests me, because I was at the Department of Health at a time when personalisation was all the rage, when everybody thought that we would see the end of domiciliary care agencies, because everybody would have their own personal assistant. The personal assistant would be a cheaper option. I have found a place where it is, just in case you're worried. But actually, councils have totally failed to do what might have been required to create that. So even if it is a cheaper option, there is definitely, in my view, a massive future for the right kind of domiciliary care, commissioned in the right way, delivering the right outcomes. Thank you.
Neil, could you say who you are when you ask your question, please?
Yes, thanks. It's Neil Eastwood. I'm on stage later, so I don't need to say any more about myself. Thanks, John. That was fascinating. I have a question around integrated personal commissioning and the rise of personal health budgets. So personal budgets haven't really impacted the sector, but do you see, I don't know if you see from where you stand, any rise or implication for CCGs and the personal health budgets and the push towards that world? Is that going to change us to a business-to-consumer model? Do you have any view?
I think it obviously comes out of exactly the same route as personal budgets. The same kind of champions of personal budgets are championing personal health budgets. I would go as far as say that personal budgets have had no impact on the sector. There are places and parts of people, there has been an increase in people taking a direct payment. But it hasn't actually made the kind of a transformational change on the way people receive care. And I don't think personal health budgets so far look as if they'll achieve that either. I think actually it seems to me even more complex because of the breakup of the NHS into so many different components that actually you can never get the money from the acute sector to a patient, except by them being in the acute sector, for example. So it'll play a marginal part like direct payments, in my view.
I think we have time for one more question, and if there isn't one forthcoming, I have one, which is around, I don't know, John, whether you've been involved at all in the trusted assessment discussions led by NHS England, NHS Improvement, actually. And I'm just wondering your comments about assessment, which I think are very, very pertinent, whether you envisage the trusted assessor concept as helping with that or not.
Sorry, yeah, and I did rush through that slide because I looked at my watch and I was running short of time. I absolutely believe that if we were focused on outcomes, we would give much more trust to providers to have confidence that they would understand what was happening. I mean, God, I tell my family I earn my money telling people the bleeding obvious. So here I'm going to tell you the bleeding obvious. The people who know the person best is the person who's visiting them regularly. Yeah? So as long as that person is trained and understands the concepts of outcomes, progression, moving forward, and isn't trapped in a kind of 1950s time warp of we must care for people and we must smother them with care, which is always the risk of the downside of the model, I would be absolutely pushing for much more engagement at all levels of providers being absolutely critical in contributing and in some stages making the decisions. So, for example, not name the council, some people in the room will know the council. In one council, to stop a service, you need a social work assessment. Well, what's that about? The care workers are saying, no, this person's fine. I think I would just say to the older person, it really looks like you've recovered, we've supported you, that's great. We're going to move on now, that's, good luck. Here's a card if you need further help, you know where we are. It doesn't need a kind of another assessment. So we've got to, even in the current climate, we can do that now, but it's still bureaucratised. And it's this bit in the Care Act about assessments. It was a big mistake. Lots of people think the Care Act is great. I don't. I think the Care Act was one of the worst. And the reason why I can argue this is go and look at the Care Act in Wales. Much better piece of legislation. Some of you may have businesses in Wales. Look at the Care Acts in Scotland. Not quite as good as the Welsh one, but better than the English one. All the English Care Act did was got all the legislation of the last 20 years, threw it all in a pile and shoved it back out at us.